Today we will discuss the iodine paradox. We all know that iodine is an essential micronutrient for the functioning of the thyroid gland. I am Dr. Neeraj. Let's see what is the clinical relevance of iodine, which is an essential substrate for thyroid hormone synthesis, and paradoxically, it's the most potent acute inhibitor. Let's discuss about the Wolff-Chaikoff effect, the emergency brake the iodine does to the thyroid gland, and the Jod-Basedow phenomenon, the gasoline on fire. For this, we should know the physiological foundation of sodium iodide symporter, which is the pump or gatekeeper which pumps iodine from the plasma into the thyroid gland. It is situated in the basolateral membrane of the thyroid follicular cell, actively pumping against a concentration gradient of 20 to 50 times that in the plasma. This pump is regulated by TSH, also sensitive to internal iodine follicular concentrations. Whenever the warehouse or the thyroid gland is full, it stops pumping in. Now coming to the effect. The Wolff-Chaikoff effect is the emergency brake. It was discovered in 1948 by Jan Wolff and Israel Leon in the UC Berkeley. They were injecting rats with increasing amounts of iodine, and this caused a sudden stop in the organic binding of that iodine to the thyroglobulin. The mechanism when plasma iodide, inorganic iodide levels reach a critical threshold. It is usually 100 times that the thyroid gland undergoes an acute biochemical shutdown. There is inhibition of TPO. High levels of intrathyroidal iodide inhibit thyroid peroxidase. There is decreased organification. The incorporation of iodine into the thyroxine reduced by monoiodothyronine and diiodothyronine stops. The result is a transient state of hypothyroidism or a dramatic drop in hormone secretion from the gland. This is utilized in the pre-surgical preparation, where we give Lugol's iodine or saturated solution of potassium iodide to a Graves patient 10 days before thyroidectomy. The Wolff-Chaikoff acutely lowers the hormone levels, stabilizes the patient for anesthesia, and prevents the possibility of a thyroid stop. Coming to the vascularity part, it's critically high dose of iodine reduces the vascularity and friability of the gland, making the surgeon's job significantly easy. Now coming to the escape phenomenon. In healthy individual, the Wolff-Chaikoff effect is transient. After about 10 to 14 days, the gland which stopped production will escape from this, and this is by downregulating NIS pump, thereby lowering the internal concentration of iodide to the below the inhibitory threshold, and the gland resumes its normal synthesis. So if a patient has an underlying autoimmune thyroiditis like Hashimoto's, they often fail to escape. These patients can develop permanent iodine-induced hypothyroidism. That is the clinical importance of this effect. And if exposed to chronic iodine loads like amiodarone or contrast also, the same thing happens as in amiodarone-induced thyroid dysfunction. The Jod-Basedow phenomenon. This is the gasoline on fire. Now let's look at some mirror image. It's named after Karl Adolf von Basedow and the German word for iodine, which is Jod. This refers to iodine-induced hyperthyroidism. The mechanism is unlike Wolff-Chaikoff effect, which inhibits the normal gland. Jod-Basedow occurs when the emergency brake is broken. This typically happens in glands with autonomy previously, toxic multinodular goiter or toxic adenoma. The substrate starvation. Imagine a rogue nodule that wants to make hormone and is limited by the iodine supply. And in that context, the patient receives a huge iodine load. Example is CT scan with contrast. And this produces tremendous explosion. The autonomous tissue, which does not await TSH or the normal inhibitory signals, start suddenly producing tremendous large amounts of T4 and T3. This is a post-CT crisis. We will discuss, for example, an elderly gentleman with undiagnosed multinodular goiter or overlooked goiter undergoes a cardiac angiogram. 2 weeks later, he or she presents to the ED with an uncontrolled atrial fibrillation, and the TSH is very suppressed. This is Jod-Basedow, how it presents. Because the tissue is autonomous, it bypasses the escape phenomenon mechanism and simply continues the fire. Now, differentiating these two is slightly difficult. Of course, by the clinical manifestations and the history of iodine exposure are the two critical things. The history of iodine exposure may be few weeks to 1 month. And remember, one is transient and self-limiting, while the other is not. Losing the brake is not. Jod-Basedow phenomenon is explosive and uncontrollable and needs significant interventions. So biochemically, you can again differentiate these two by looking at the history of exposure to iodine and the thyroid profile, thyroid hormone profile, where the TSH will be suppressed in Jod-Basedow severely. This is how we should think about amiodarone induced as well, because amiodarone contains 37% of iodine by weight. Now coming to Jod-Basedow, amiodarone provides the iodine substrate to latent autonomous nodular goiter. This is true hyperthyroidism in AIT type 1, amiodarone-induced thyrotoxicosis. While AIT type 2 is not Jod-Basedow. This is a direct toxic effect of the drug on the myocyte causing leak of the thyrotoxicosis. And this determines how you treat. You use methimazole to block TPO enzyme that is overutilizing iodine in type 1, but in type 2, this does not have any effect, and you use prednisolone to stop the inflammatory leak. Now you can think that so many CT contrast done and so many people have got, why doesn't everyone get sick? The human thyroid is an evolutionary masterpiece of adaptation. In the vast majority of our patients, the symporter and the escape phenomenon from Wolff-Chaikoff maintain euthyroidism despite wide fluctuation in iodine low concentrations from the modern diet and the medical procedures. That's the wonder of nature.